There we go. And with that said, I'm going to stop sharing my screen. And I am going to invite my colleague, Alison Footman, to the proverbial Zoom stage, who will be moderating the rest of this discussion and introducing our stellar speakers. Alison, over to you.
Thank you so much, Jim. I just want to welcome you all to this conversation today. We initiated this webinar because it is STI Awareness Month here in the US, and we definitely wanted to bring more awareness to STIs, but also to sexual health overall. Our speakers today are phenomenal. And I also want to plug that we were so fortunate to plan this webinar, AVAC, with Jim Pickett and Lynn Barkley from ASHA, the American Sexual Health Association. And so with that, I want to turn it over to our first speaker, Dr. Joseph Cherabie. Sorry, I've not had enough coffee this morning. And he will be speaking about sexual health messaging, trauma-informed care, and cultural humility to improve patient experiences. So over to you, Joe, and we are super excited for your presentation.
Good morning, everyone. Thank you so much. I'm so excited to be here. And I've just been seeing all these people scroll in and I'm like, oh my goodness, so many. This is like the happiest I've been starting a morning, especially being minimally caffeinated. So I'm going to try to share my screen real quickly. And then we are going to do a slideshow. Can everyone see my slides okay? I see some nodding heads. I love nodding heads. That makes me very happy. All right, so today we are going to be talking about sexual health messaging, trauma-informed care, and cultural humility. Just some background for who I am. My name is Joseph Cherabie. I use he, they pronouns. I am an assistant professor in the Division of Infectious Diseases here at Washington University in St. Louis. I am also the PI for the CDC Track 2B Midwest Capacity Building Assistance Program and the Associate Medical Director for the St. Louis STI HIV Prevention Training Center, as well as the Associate Medical Director for the St. Louis County Sexual Health Clinic and a clinical ambassador for the Let's Stop HIV Together campaign. All of this is to say that these are things that I care very much about. Talking about STIs, HIV, and how we talk about STIs and HIV is something that I feel very, very strongly about, because we are here as sexual health practitioners who want the best sexual health for our patients. And so I'm going to be giving a little bit of background with respect to what sexual health messaging looked like, how it currently looks like, what trauma-informed care is, and how we can institute trauma-informed care within our practice, as well as cultural humility. So to start us off, it's morning time here in St. Louis. So I want you all to think about, was there ever a time where you were shamed or blamed by a healthcare provider and that made you want to change your behavior with a positive mindset? In other words, was there ever a time when someone made you feel ashamed of your sexual health and that didn't destroy you, right? It didn't make you feel like you need to change out of complete shame and negativity? And I can't think of that time. I myself have been a patient in an STI clinic. I have been a patient in a PrEP clinic, and now I work and run an STI and a PrEP clinic. And so I myself have been told that I have too many sexual partners, that I need to change the way I'm having sex, that I am high risk. And I can tell you that that's a trauma trigger for me. The moment, if anyone is in a room with me, whenever someone says high risk individuals or their risk factor is that they are MSM, immediately my brain shuts off and I just want to take the microphone and be like, what do you mean? I'm not high risk. How dare you? Right. And so I want you all to keep that mindset and think about how shame has showed up and sex negativity has showed up in your own experiences of sexual health care. And I love that Jim started with this definition of sexual health. I start each and every one of my trainings with this definition of sexual health by the WHO, because it highlights that sexual health is a state of physical, emotional, mental, and social well-being. And that is not merely the absence of disease, dysfunction, and infirmity. The way that we are trained in medical school to talk about sexual health as healthcare providers is to do a screening for disease processes. Does it burn when you pee? Do you have discharge? Is there bleeding anywhere? Is there a penile lesion? Is there a vaginal lesion or a vulvar lesion? We are talking about disease processes, but rarely do we talk about pleasure, the joyful aspects of sex, the stuff that sex is supposed to be. And so we're going to try to change that a little bit. And one of the things that I love sharing with people is the new CDC guide to taking a sexual history. Now, I'm a little biased. One of my closest colleagues was the primary author for this. But what I love about this sexual history taking guide is it focuses on sex positivity. It is gender inclusive, and it focuses on the fact that a sexual history should be taken as a routine part of healthcare. The more we normalize taking a sexual history in whatever healthcare setting that we are in, the more it just becomes natural, and our patients feel more comfortable sharing this information with us. It helps identifies one's likelihood for STIs, of course, but it can also help address one's needs for wraparound services overall. So how do we start this conversation? Now, it is really important to put this into practice, right? And one of the most important things is asking consent and putting the power within the hands of our patient. A lot of the talks today, I think, are going to be focused on patient-centered language. And I think the easiest way and the best way is to ask, is it okay if I ask you some questions about sexual health? Not, I am going to ask you some questions about sexual health. Asking, is it okay if I? That automatically puts the power within the hands of the patients and allows them to be able to say no and understand that different cultures have different responses with respect to asking about sexual health. You also need to understand that many individuals have experienced trauma with respect to their sexual health. And so saying that and understanding that some of these questions may bring up some uncomfortable feelings, and checking in with our patients regularly is very, very important. The last thing is if ever I'm rushed for time, one of the easiest questions to ask is, do you have any questions or concerns about your sexual health that we can help with today? And that, again, opens up the conversation for our patients. We also need to be aware of the fact that for years, all of our messaging with respect to HIV and STI prevention was fear-based, and was because of the fact that HIV was and still remains in many parts of the world a deadly disease. However, we have to understand that we have new modalities available to us now. We have HIV PrEP, we have condoms, we have different methods of STI prevention, including vaccines. We have regular access to STI testing and treatment. We have at-home testing. We have all of these things, and yet our messaging has not adapted to the times that we currently are in. We still are basing the majority of our messaging on fear-based messaging. And you can see here that a lot of these messages that are actual public health campaigns are based in fear, shame, and stigma. And while we are trying to prevent disease acquisition, inevitably these messages end up stigmatizing those individuals who happen to have the disease process, as if they are quote unquote diseased, as if they are quote unquote high risk. And so I am full, if anyone has heard me on Twitter, I am all for getting rid of risk, because we don't need to talk about that. What we're talking about is likelihood of disease acquisition. So why aren't we talking about that without using negative language? We need more trauma-informed prevention because we have antiquated prevention modalities and there are very few trauma-informed prevention models. We also need to understand that we need to re-engage our patients, and we need to create a welcoming atmosphere for patients to feel comfortable sharing their sexual health experiences without feeling judged and shamed. We want our patients to come back to our clinic. We want them to feel comfortable coming to our clinic. We want them to be able to say, hey, I had sex with 10 partners over the weekend, and not have us bat an eyelash at it. Because guess what? Those people are going to have that sex regardless. But what changes is we need to create a safe, welcoming, wonderful, sex-positive environment in order to make sure that we engage them into care. So with that, let's talk about some facets that we can do, some things that we can do in order to make sure that individuals are welcome in our clinic. Number one is gender affirmation. And I know that this is a hot button issue in the United States, but I always say gender affirming care is not for select individuals. Gender affirming care is for everyone. Gender affirming care is me acknowledging individuals how they would like to be acknowledged. And there are 4 facets of gender affirmation. Number one, the social aspect, which is the externalized gender expression of individuals, what their name is, what their pronouns are. talking about the psychological, internal felt self, and those might be different. I myself identify as genderqueer. Internally, I felt genderqueer, but I never really externalized it very frequently. And so the internal psychological self may be different from what is socialized or what is shared externally. The medical aspect, be it gender-affirming hormone therapy, surgical interventions, and body modification. And unfortunately, this is what most people associate with gender-affirming care. However, there are trans individuals who do not have medical gender affirmation, and there are cisgender individuals who do have body modification and medical aspects of gender affirmation. The last thing is our legal gender markers as well as name changes. And so again, all of these are important for us to be able to evaluate, and a lot of these can be evaluated on an intake form that allows individuals to share this stuff anonymously without person-to-person interaction and without fear of misgendering individuals. Sex positivity. We use this term very frequently, but what is sex positivity? This is recognizing that sexual pleasure is an important component of health and respecting diversity in practices and partners in our patients, recognizing that everyone is deserving of non-judgmental care and promoting good and healthy sex. In other words, everything that is not in this poster of this poor guy who had venereal disease, because of course venereal disease can be cured, but there's no medicine for regret. This is one of the saddest posters I've ever seen. He looks very depressed, but this is very important for us to remember that we must focus on sex positivity and trying to create a welcoming, patient-focused environment in our clinics. And we have to acknowledge the elephant in the room. The fact is that lesbian, gay, bisexual, queer, and transgender individuals have experienced trauma at the hands of sexual health, at the hands of healthcare systems. LGBT individuals have commonly experienced this. This was a Center for American Progress survey in 2017 that showed that 8% of lesbian, gay, bisexual, and queer individuals said that a doctor or other healthcare provider refused to see them because of their actual or perceived sexual orientation. 7% said they experienced unwanted physical contact from a doctor. That goes up to 29% for trans individuals. 29% of trans individuals said that a doctor or other healthcare provider refused to see them because of their actual or perceived gender identity, and 29% said they experienced unwanted physical contact. That's nearly 1 in 3. This was 2017. And currently, we live in a state in which this is the modern LGBTQIA plus health, in which according to the ACLU, there is 461 anti-LGBTQIA plus bills in the United States. I myself live in Missouri, in which transgender healthcare for adults is currently under attack. And so what does this mean? It means that we are legislating the healthcare that individuals receive. And I'm just focusing on the LGBTQIA plus community. This also stands for Black, Indigenous people of color. This also stands for cisgender women. This also stands for a wide variety of historically neglected communities at the behest of the healthcare systems that we are a part of. And we have to acknowledge that stigma and discrimination ultimately decreases access to care. If individuals are too scared to acknowledge themselves or too scared of stigma and discrimination by their healthcare provider or being criminalized for who they are, then inevitably they will not come into our healthcare systems. And so we must acknowledge the importance of messaging and trauma-informed care within our messaging. And so what is trauma-informed care? It is the human service field that assumes that an individual is more likely than not to have a history of trauma. And trauma-informed principles recognize the presence of trauma symptoms and acknowledge the role that trauma may play in an individual's life. I like to view it in the sense of every single individual who walks through my door carries with them every single experience they have had with the healthcare system through that door. And so we have to, there are no difficult patients. There are no patients who are hard to reach. These are patients who have been historically neglected or traumatized by the healthcare system. And so there are big T's and little T's. Big T's are stuff that are socially validated. These are the stuff that are that make headline news, right? These are things that if anyone talks to you and says, I experienced this, they will say that, oh, that's traumatic, right? Things like natural disasters, mass shootings, sexual violence, war, terrorism, torture, burglary, car accidents, kidnapping, and physical abuse. But then there are little T's, and these are tiny little cuts that over time build up into something much bigger. These are microaggressions, for example. And these are things that some people may say, oh, you're overreacting. I don't know if that's really what that person meant, right? But over time, if people experience these, then it builds up into a big T. And so these are things like weight stigma, body shaming, poverty, discrimination, transphobia, harassment, bullying, neglect, heterosexism, racism, and slut shaming. You can see how many of those over time build up in our field of sexual health and can build up to a big trauma. And so with that, I want to propose some language shifts that are more trauma informed, right? And I know we don't have a lot of time here. I'm rushing through this because I really want to, this is stuff that I talk about like for a 4-hour long course, but I want to give you all some practical terms in which we can use. Prevention in and of itself is the act or practice of stopping something bad from happening. STIs are bad. HIV is bad. So instead of that, let's talk about sexual health goal setting. Let's create patient-centered language and talk about what good sex means for our individuals. My goal is to make sure you're having the sex you want to have in the way you want to have it with the people you want to have it, full of consent, free from coercion, and while trying to decrease the likelihood of you acquiring STIs and HIV. Safety is the condition of being protected or unlikely to cause danger or risk. And so we say safe sex all the time, usually in the sense of condoms or barriers. However, let's talk about sexual health and well-being, empowerment, pleasure, and consent. It is more important for me to make sure my patients are having pleasurable, consensual sex than to say that they are having safe sex. Risk is a huge one. Again, this is a situation involving exposure to danger. Instead, let's talk about likelihood of acquisition, susceptibility, sensitivity, vulnerability. If you're talking about statistics, use a different term than hazard ratios or risk ratios. You can say likelihood, rate ratios. These are all neutral terms that do not stigmatize our patients. Non-compliance is a big one that follows our patients a lot. So instead, let's talk about, are you able to take your medications? Let's talk about missed doses and how we can help you. And instead of transmission, let's talk about acquisition and be more patient-centered and focused. And so again, examples of issues with messaging, all of these are issues. Instead of it saying AIDS, which again, there's a certain definition for AIDS. Let's talk about uncontrolled or advanced HIV, putting the power back in the hands of the patient. Your results came back clean. Good news, all your results came back clear. This is something that we like to say, but in fact, that means that if someone has an STI, what? It means they're dirty. It means they're unclean. Unfortunately, you have HIV. HIV is a manageable condition these days. And so let's talk about your HIV result came back reactive. So let's talk about what that means and how we could get started on antiretroviral therapy today. You are high risk, I've already said. Remove that from your language and lexicon. Do you know how you contracted HIV is harking on trauma? And instead, let's talk about what this diagnosis means and how we can help individuals. Can you pull your pants down for me is something that we use all the time in our clinic. We're not doing it. It's not for me. It's can you just pull your pants down in general, right? You're not doing it for me. And then please slide down the bed and understanding that a bed in and of itself is where a lot of trauma and sexual assault has occurred. And so calling it a table is more trauma informed. So these are the 5 Ps. We all know what they are. Partners, practices, protection from STIs, past history of STIs and pregnancy, intention that have been adapted. But instead, I also want you to consider 3 additional Ps. Preferences, talking about what our patient's sexual health preferences are. Pleasure. It is important to ask about sexual pleasure because it leads to a further conversation. Partner violence is another one to talk about, and we must ask our patients about partner violence, understanding that many individuals, almost 1 in 3, have experienced sexual violence in their lives. And so the patient's experience starts from the moment they enter the office, and we must use intake forms to our power, asking a 2-step gender question, what their sex assigned at birth is, what their current gender identity, be aware of posters and messaging throughout the clinic and what that might reinforce, avoiding risk and shame-based language, and sexual health goal setting with patient mindset and being front and center. This is just a great Twitter thread that shows how people have had bad histories with sexual health and experiences. And again, I'm a clinical ambassador for the Let's Stop HIV Together campaign. Focusing on stigma and decreasing stigma in healthcare is a huge focus of this campaign. So we have a ton of resources that we are more than happy to share. But this is my contact. I know it was rushed. I went a little over time. I apologize, but I hope that I will be available to answer any questions. And I will stop sharing.
Thank you so much for that amazing presentation. Some quick tidbits that I took away is really the need to create and provide these safe, welcoming, and sex positive spaces. Also shifting some of our language to focus on sexual health goal settings, really making sure that we're putting patients first, but we're also putting ourselves first. So making sure that we demand more from our healthcare system so that we can all have, the sexual lifestyle or the sexual pleasure that we want and need. And so we really appreciate your presentation, Joe. It was so amazing. There are so many comments, or questions, comments in the chat. You can also follow us along on Twitter, where we are trying to capture some of these inspirational tidbits the best way that we can in 200 characters. And so now we want to move the conversation over
Hey,
to...
Allison?
Yes.
I sort of jump in. I see Kevin has a quick question.
Yeah.
Maybe we could take a moment to have Kevin ask his question briefly.
Of course. Kevin, would you like to jump in to ask your question?
Yeah. I work at Haymarket Center in Chicago, Illinois, in the Health and Wellness Department. I've been in HIV and STI prevention for the past 17 years. Joseph, what if I'm a gangster disciple on 79th and Cottage Grove and you say your result came back reactive? What the fuck does that mean, bro? I don't understand reactive. You would have, I feel like, and I have, because I've had a GD flip the table on me when I've given him a reactive result. And then I was like, are you done now? He didn't think I was going to be professionally ghetto with him. So like from that perspective, I mean, trying to avoid saying unfortunately, which I agree with, how would you go about saying using different clinical language or a different language besides the clinical language in order to tell this person who's never used that word before and that word isn't used in his social networks?
Yeah, and I think reactive is a term that we want to make. It's like fetch, right? We want to make it happen, but sometimes it just doesn't work, right? And people know what positive and negative means. So what I really want to emphasize here is that your screening result came back positive. That's what we mean by reactive. We need confirmatory testing in order to make sure that this is truly an HIV infection. But this is what came back positive right now and what we typically know as positive. And there are some people who view positive as being like positive in terms of like, this is not, you don't have a disease. I always remember that episode of The Office in which Kevin receives the pathology result that this is negative and they think that this is a negative outcome, right? So being clear of what we mean. And sometimes one of the language shifts that was recommended by a colleague of mine is saying there's chlamydia in your penis, or we found gonorrhea in your vagina, or any of that language in which we are specifying what we found where, and being clear and saying we would like to get you treated for this thing, and not saying positive or negative, not saying good news, bad news, not saying unfortunately, yay, just being all of your results came back negative for disease processes. This means that there was no chlamydia, gonorrhea, syphilis, or HIV found in any of your specimens, something like that. Just being very clear of what you're searching for and what that means and what a positive result means and what the next step means. Hopefully that answered your question. Great. I got a thumbs up. I love a thumbs up.
Perfect. Thank you so much for that question, Kevin, and for such a great response. So now we want to move this over to Dr. Keosha Bond, who will be discussing barriers that prevent providers and patients from discussing sexual health and strategies to better promote these conversations. So over to you, Dr. Bond. We are so excited for this presentation.
Can y'all see it okay? Or how we doing with this? Can you hear me all right?
Yes, we can hear you and see you.
Okay, great. We can get started. Hello, I've been bumping to the music from this morning, and I really enjoyed Joseph's presentation. And I love the fact that all of these things are really complementing each other, these presentations today. And so today, I'm going to talk to you about promoting sex positivity and wellness in the healthcare setting. And some of our objectives today are looking at defining the barriers that may prevent providers and patients from discussing sexual health issues, as well as identifying key components of a comprehensive sexual health history using pleasure-based approaches, and discussing these strategies for how to having these conversations about sexual health and wellness to minimize sex-related stigma. And so just kind of give you a little background who I am. Am a professor at the CUNY School of Medicine. So I am training future physicians, basically. I'm in that area, but I'm also a sexual health researcher. And though a lot of my funding is related to HIV, I like to use the word sexual health and wellness, mainly because sex is more than disease. A disease. And so a lot of my work is focused on looking at sexual health and understanding that sex doesn't happen in the clinic. It happens outside the clinic. It happens between individuals. And we really need to center that. We forgot, especially with HIV, that sex was involved. And because of that, we have always demonized it. We have always created these stigmas related to sex in general. And so no one really has time to actually enjoy sex, really. And I'm speaking from experience in the sense of that I grew up in a generation that's only known HIV. From the Bronx. And if you know anything about the Bronx, you know how that community in New York City in the United States, I should be clear, that that city has been impacted, that community has been impacted by HIV for so many years. And not only just HIV, but we experienced also the crack epidemic. So imagine growing up and going through puberty at a time where we were so infused with so much information that was negative about our sexual development. And so that's how I got to this point in my career. We wanted to become a sexual health educator as well as a researcher. And so we've seen this, and that means it's important for us to acknowledge is the definition of what sexual health is. And I always like to look at it and look at that fact that it's saying that it's a state of physical and emotional and mental and social well-being. And the most important part is that it is not the mere absence of disease or dysfunction or infirmity. And what it basically is telling us that we cannot really understand or make operational without a broad consideration of sexuality, meaning that there's so many different things that's included in sexuality. And we really can't, at this point, just look at it as what happens in a clinic setting. We need to look at it, all the different factors, intimacy, pleasure, relationship, all those different things, and look at how these have an influence on our behaviors and outcomes as they relate to sexual health. And that happens because so much of the work that we've been doing related to sexual health has had a pleasure deficit. And really, this is just like the oversight given to the importance of pleasure and understanding the sexual behavior and family planning. And again, when I talk to people, I like to talk about my experience. What really got me to this point was realizing when I became a mother and I'm talking to my kid and I'm trying to raise a sex positive kid, and we're having these conversations about sex from the time that he's a young boy and now he's a teenager. Is like, what is important when it comes to sexual health? And three things that I told him was consent, communication, and pleasure. And I told him in general, if you could get to those three things, sex can be very good for you. Sexual health, your wellness, everything will encompass that. And so I use that model when I talk to everyone about it. It is like, so he's helped me grow in that way. And so what that challenged us to do is to really move beyond the 5 Ps that were the standard of talking about sex and taking sex history. The CDC had recommended these like for years, and this is probably the standard that was used before with looking just at partners and practices. And past history of STI, and also what type of protection are you using, and also pregnancy. But our research has shown that healthcare providers are really missing opportunities to gauge people in sexual health. And people need sexual health care that can support sexual satisfaction, functioning, concern, and support both gender and sexual identities. You know how many times we have conversations and talking about HIV prevention strategies such as PrEP, and there's so many missed opportunities, mainly because there are physicians and providers who are making assumptions about their patients just based off of how they appear to them, based off of factors such as, oh, your marital status, oh, what is your sexual identity? What is your gender identity? These things, you could either miss an opportunity to engage, or you could increase the stigma that they're experiencing because of their identity instead. So it's important for us to think about ways that we can engage people in these conversations without making our own assumptions. So when I usually talk to students about this and other providers, one of the things that common pitfalls of providers is that they're not asking about sex at all. They ignore it. They act like it doesn't exist, that people don't have sex. People will ask you about your dental care before they ask you about your sex, if you're having sex at all. And they're not thinking that they don't have enough time or enough expertise. And, on some levels, they can be right with the expertise, in the sense that a lot of the schools that we have are not focused on training sexual health, related to sexual health, anything related to talking about sexuality with the patients. But this is an opportunity in different settings. We can't rely on specialists or providers who are working in sexual clinics to just ask about these questions. These are things that are part of people's lives. This affects their health, their overall well-being. So we should include it with every other things. If you're going to talk about your cholesterol, you should talk about sex also. And we tend to rely on risk categories, which again is not really person-centered. But who wants to hear that the sex that they're having is risky? How open do you think someone is going to feel if they feel that if they're engaging in sex, and that because of their identity is something that it should be looked down upon, it should be associated with shame? And thinking of that other providers, again, would address the issues. We always want to pass it off to someone else. We're like, this is not the place for this. This is what I do. I serve this part, whatever. If the issue comes up, or if there's an opportunity to have a real conversation, we should all be open to engaging about it. And so ways around this, and this is what I've been seeing to be very effective with providers to get around the pitfalls, is to really be open and honest with patients, and to give patients some space and time to talk about things that they're experiencing, and allow them to have a trusted relationship. One of the things that like I said, I do research also that one of my participants are always saying is that their trusted providers speak to them, not at them. They give them the time and the consideration, and they don't really center it around everything that's wrong in their life. They try to empower their patients. And so I think it's important for us to do that. And either if you are a provider or you are working at the front desk, these are strategies that you should use when you're engaging with your patients that come in. And you should also ask about concerns related to our satisfaction with sexual functioning. There's many issues that come on that have nothing to do with disease or STI disease. There's other factors that influence how people are experiencing sex. So it's important for us to have an open mind and, again, center it around the patient. And so that puts us into thinking about adding the 6 Ps, which really is the plus. And the plus includes pride, problems, and pleasure. So when we talk about pride, I try to encompass recognizing and honoring someone's sexual and gender identity from an intersectional perspective. That's looking at the historical context, that's looking at cultural and structural factors that may influence how they're perceiving themselves, and also how their sex and identity is being perceived. So when we're engaging with I say participants a lot, when we're engaging with patients, use their chosen name, their pronouns, ask them how they would like their body parts to be identified, and respect their partnering decisions. We have the tendency to speak in binary views about everything, not just gender, but in sexuality. And we only have like one, people are either heterosexual, gay, or bisexual. Sexuality is a spectrum, and we need to be able to understand that and understand what those things mean also. And then also looking at problems, which is addressing difficulties when you have sex. These examples include like pain, discomfort, vaginal dryness, a lack of arousal, a lack of orgasm, lack of erection, low or high levels of interest in having sex, and having mixed match sex drive with your partners. All these things can have an influence on how you are engaging in sex, and also the type of sexual health practices that you're using. And here's the important part, and I always like this, is talking about pleasure, because I feel like in general with pleasure, you can address all the other P's, and this is talking about the partners, the practices, the past history of STI protection and pregnancy. If you include pleasure, if you center pleasure, you're going to make sure that that discussion about sex and sexual health is going to be inclusive, it's going to be person-centered, and it's going to show compassion, and most importantly, it's going to remove the stigma that is usually associated with sex. And so here are some questions that are pleasure centered, but if you look also, you can see the examples, like how is your sex life going? What concerns do you have about your sex life? You ask those questions, you can get at past history, the protection factors, pregnancy problems, and practice. Are you currently involved in any sexual relationships? Is the sex you're having pleasurable for you? If no, why not? Are you and your partners on the same page about what's pleasurable? Do you and your partners talk openly about sexual desires, boundaries? Are you able to advocate for sexual pleasure in your relationships? You see how I use certain words like partners? I didn't say your husband, your boyfriend, your wife. I just said it in general. And I use very gender neutral terms in this practice. And I think it's important for us to do that when we're talking about sex, whether we're talking about it in the clinic section, whether we're doing it in a health education space, or if we're writing about it in our research. It's important for us to focus on very gender neutral language. And so in these clinical settings, it's important that we avoid assumptions, to avoid assuming gender, sexual identity, and sexual behaviors with patients. So instead of "how may I help you, sir," say "how may I help you." Instead of he is here for his appointment," say "the patient is here in the waiting room." And instead of "do you have a wife," say "are you in a relationship?" These kind of questions and the phrasing of the question leave space open for people to really talk about themselves and not feel pressure or not feel shame associated with their identity. And now we're kind of trying to talk about the ambiguous and stigmatizing language. And this, I feel, is calling out not just providers again, but us as healthcare, health educators and researchers. We have this tendency to use a lot of ambiguous language when we talk and when we write, and this language can be stigmatizing. And so we're going to talk about stigma and the influence of how stigma affects people's sexual health and health outcomes. We need to be mindful of the kind of language that we're using. And so one of the reasons why we do this and why language matters is that describing sex as unsafe or risky really perpetuates stigma, and it undermines our efforts to promote sexual health. And as you can see here in this diagram, this is a diagram looking that describes, shows a pattern that occurs when marginalized groups experience stigma due to HIV status, sexuality, their gender, drugs, and drug use and sex work. And using stigmatizing language is associated with transmission of bias, which in turn is associated with the reduced health care access and quality. And as public health professionals and clinicians, we legitimately have used as condomless sex as being unsafe or risky through the lens of how we've been trained as public health professionals. But sexual health is defined not only by the absence of disease, but by the holistic state of the physical, emotional, mental, and social well-being in sexuality. So by using this risk-based language to describe sexual behaviors, we perpetuate that long history of fear-based messaging related to sexuality. And this contributes to HIV, STI stigma, which can hinder both seeking of sexual health care by those who need it and the provisions of the providers. And it's important for us to also understand that it disproportionately impacts the sexual health of people from racial and ethnic minority backgrounds and members of sexual and gender identity, people of low socioeconomic status. So your sexuality isn't just about who you having sex with, but all the identities that you have and that you represent. And if you are an individual who is living with multiple in this society and experience multiple levels of oppression and marginalization, that in too is also going to have an effect on your sexuality and on your behaviors. So when we look at why not making sure that the language we use is not, how we can say, ambiguous, really using the unsafe and risky to describe sex is scientifically imprecise. Basically, this imprecise language conflates risk derived from individual behavior and risk derived from contextual factors. And the risks associated with condomless sex can vary dramatically based on the context and based off of like the sexual encounter, a person's social, economic position, or their role within a broader community. So in terms of sexual encounters, relevant contextual questions that affect sexual behaviors include the following, like is highly effective contraception being used? Is HIV PrEP being used? These kind of questions are more precise and more at the issues related to the individual than just saying, oh, they're having condomless sex, and therefore they are engaged in what we consider to be unsafe and risky. So here's some examples of the kind of language we've been using versus the kind of language we should shift to using. We use language like unsafe sex when we really should just look at, is this are you engaging in condomless, receptive, or anal vaginal sex? We use risky sex behavior. Again, is it condomless or receptive? And risky sex, are you having multiple anal and vaginal sex partners without condoms or PrEP regimen? And sexual risk behavior. Ask them, are they having condomless sex? Is there no PrEP regimen? Because now we know it's not just about using condoms and it's not just about using PrEP. It's important for us to think about what works for that individual in their lives and how we can support them in making these decisions. And so lastly, at the center of pleasure and sexual health is respecting and supporting the patient's gender, sexuality, and their health desires. And that includes the language that providers and public health professionals use in communicating. I really want to let everyone know that sexuality and sexual health are important parts of healthy living and wellness for most people. And it can be a tough thing to talk about, especially in a clinical setting and elsewhere. I know we have friends, we have families, but if we want to do the work to address sex-related stigma, we need to check the language we're using when we're discussing it. And we also need to be ready to talk, but also be ready to listen, which is something that sometimes when we wear certain hats and we have certain degrees that we think we don't have to do. But I think it's important when we're in these roles to listen to the people and the patients and understand their needs and desires. And Thank you for listening. If you want to learn more about some of the work that I'm doing, you can follow my lab at the Love Project Lab on Instagram. And this cartoon figure is me when I'm talking on Instagram. And you can email me, and here's my information. And thank you again for your time and consideration.
Thank you so much, Dr. Bond. We really appreciate your presentation and all of this amazing information that you provided. And so I will give a brief little synopsis of some of the tidbits I heard from you while we wait for one wonderful person to come off camera so that they can ask you a question. But really, during your presentation, I think I took away the fact that sex happens between individuals and not in a clinic. And that's something that we all have to remember when talking to patients or other people about their sexual health. Also, the importance of empowering patients, incorporating pride, and that sexuality is a spectrum. Like, that is wonderful. And so now we invite anyone who might have a question to come off camera real quick for Dr. Bond. Yes, Dana.
It's not really a question as more as it's some way of helping people to assess their own sexual judgments. And I'm not sure how well these are done this day. I did this training many, many years ago. It was a sexual reassessment seminar, and it just covered everything. So when somebody walks into my office and asks me a question about something, I don't flinch at it. I had a young man who walked into my office one time and said he was doing sex work, and he said, "Hey, my John wants me to be a submissive. What does that mean?" And I'm like, "Well, let's sit down and talk about it. That's not going to happen. We're not going to have that conversation in 5 minutes. It's probably going to be at least a half hour in the situation." So if there's anything that you flinch at, just being willing and open to educate yourself on the full breadth and aspect of sexual expression in our world, so you don't end up flinching when somebody comes in and says, "Well, I did this. Is this a problem?" in the situation, and kind of go from there.
I totally agree with what you're saying. And I tell my students, and I say this to myself and even colleagues, if you're talking about sexual health, you should always learn. You never know everything. And things are changing, and there's experiences that we don't fully understand. So dig deep, do the research, and understand and talk to people who are experiencing this. I am a real, and I tell that, I was like, I am really an introvert. I don't even know how I get in positions to do talks, large crowd, but one of the things public health has taught me is that I have to be able to talk to people. And so I use that as a way for me to learn, really. I learn from the people, and I try to shape what I say and how I say it based off of those experiences, really.
So we will let Lynn ask their question, and then if everyone can choose the Q&A function or the chat, we will answer more questions at the end.
Thank you. This is so amazing. I'm Lynn Barclay from the American Sexual Health Association. We're a 100-year-old plus nonprofit that's been dealing with educating the public and providers and pretty much everybody on the subject originally of STIs, and now the bigger subject of sexual health. So when Alison and I talked about this several weeks ago, it was my suggestion that we do the two sides, because when ASHA is trying to educate the public about how to be sexually healthy, we bump up against how do we change behavior, right? We want people to get tested, for instance. We do major testing campaigns. And what we find is that we get advice, research that says people will get tested if you use risk-based, like 1 and 2, 1 and 4, kind of thing, which I don't like. So we're constantly trying to figure out how to do both things, how to get people to do what is safe for them, right? Healthy, let's reframe that, healthy for them, without using that language. So that to me is a challenge. It really is. So I get it. We raise awareness without stigmatizing. We do that, but I say that, and yet we find that when we do our testing campaign, when we give the like 1 in 4 statistic, it gets more people to go get tested.
I know it's interesting because it's you know we've been trained, and I even I'm not knocking anybody or anything, but I said no one really knew who the CDC was until we had COVID here. Like like no one was following them on Twitter or Instagram and stuff, and it's important for us to figure out ways to talk to people, and that's why I really my approach is really centering it around wellness. And about these are the same like tests that you need for like the same way you take tests to test your cholesterol levels or see if you have diabetes. And so that's how I like to look at it. Like this is a routine. This is part of your life. These are what you should do all the time. And, and I try even when I'm talking in community settings and with people, whether I'm talking in a church or I'm talking to schools or wherever it may be, I try to tell people, think of this as this is your full body. One part of your body is not excluded just because because it's related to sex. This is your full body. This is a full wellness capture. And so I really would like to see more approaches like that, because I feel that even using the numbers, sometimes that's good for educating people about, like just awareness about how disease is prevalent in different areas and neighborhoods, but it really takes away from the person. We're so focused on these numbers that we forget that these are human beings and they have experiences, they fall in love, they fall in lust, they have, and so it really should just focus on their wellness and not on what bad things can happen to them. Because that's what I feel sometimes what the numbers are saying, is that bad things are going to happen to you. So therefore you need to get testing. No, this is just how I take care of myself. That's it. That's how you should approach it. I'm taking care of myself. I'm taking care of my body. That's all it is. And even sometimes when I'm talking to like cisgender women, especially cisgender Black women, like this is a way of self-care also. You can't make decisions for everybody else in your life, but you can make some decisions for yourself.
Thank you. It's a very frustrating.
Yes.
To move the dime.
Yeah.
This is what we're always trying to do, is to move that dime. And this is it's just a continuous battle for me personally and professionally, because I get a lot of pushback, on how do we actually move the dime and do what you're saying, because I agree with you completely. Thank you.
Well,
Thank you.
thank you so much for this amazing conversation. And now we will move to our last presenter of the day, Mr. Mark Kaigwa. And I apologize a lot today because I think I have mispronounced everyone's name I have said today. And I am incredibly sorry. I'm so incredibly sorry. But now to our last presenter, who will be focusing on discussing a campaign that advocates for conversation about sex to focus on personal pleasure and well-being. So off to you, Mark.
Thank you. I might need somebody to give me a verbal yes if you can see my screen.
Yes.
Looks good.
Wonderful. So really happy to be here, and I appreciate the invitation to come and share. So my name is Mark Kaigwa. My pronouns are he, him, and I'm the founder at Nendo, which is an African research and marketing firm, just working across the continent. And part of what I'm here to share today is really reflections and building on the last two presentations. And I really love just the engaging conversation in the chat as well. And so what I'd like us to just take a couple of seconds to appreciate in terms of just the continent and some background is, one, just a couple organizations I'm going to mention. So one, there's Nendo, that's us. And then I'm going to speak about some work we did with the IPPF, which is the International Planned Parenthood Federation, and their Africa region. And the collaboration we did was led by Mahmoud Garga, who leads communications there. And then the Pleasure Project. And I'm glad to have, I think it's Jaime who might be here in the chat from the Pleasure Project, but Anne, Francesca, the entire team there. And as I'll reference what's called their pleasure principles, and really just explore a digital-led conversation where we used smartphones and screens to start a conversation that was quite different as far as sex and sexuality, in a way that, as far as we can tell, is one of the first to break through in this sort of fashion. So that's what I'm here to share about. Now, if I just give you a bit of context, so one, as far as the sub-Saharan African continent, so the whole African continent is 54 different countries, and some are complete night and day as far as just the differences and the nuances. However, we tend to look at Africa really as a region, but it's certainly no country, and you do have all of these respective challenges and opportunities that are there. But as far as HIV is concerned, it is home to 2/3 of all the people living with HIV globally. And on top of that, can be one of the hardest hit, I think, followed by Asia. Now, what I like is the way that the conversation has moved and shaped as far as the definitions of sexual health. Now, one of the challenges that Africa is particularly going through right now is laws and national conversations that are increasingly showing that people across the LGBTQIA plus spectrum are, and I'm not using this as a turn of phrase, are in harm's way, and in some cases, just their literal expression of love or their gender identity is a matter of life and death for them, to the degree that even if you look as recently as the last 90 days at Uganda, Kenya's neighboring country, because I'm on this call from Kenya, and just you look at what some of the legal conversations are, and the harm, the big T trauma that some, if not a number of people face, and the fears and challenges that they have to weigh on their shoulders simply just for expressing themselves. That's part of really the context we're looking at, even before we start looking at Treasure Your Pleasure, this pro-pleasure comms campaign that we had and led and delivered online last year. Now, one of the things about Africa as well is that to a number of people, Africa is seen as this place where we send aid, we send support, we send money, we do charity projects, right? We're constantly giving to Africa, and Africa, in a really harsh way of saying, is seen as having this begging bowl, or not really able to self-determine or act and express one's agency or really have anything it can do. Part of what this campaign that I'm about to show and share from was able to accomplish, that I'm quite proud of, is this idea that there is at least a set of creative ideas, a set of pro-pleasure communications, led by Nendo and really guided, technically speaking, by the Pleasure Project, using their 7 pleasure principles, of which AVAC and IPPF are both endorsing organizations. And I encourage you to check them out. And then IPPF itself in the Africa region, having a conversation across it's present in 30 plus countries on the continent, but we spoke to 6. Now, why do I start here? Because changing the narrative was the fact that this campaign, the way it was ran, and I'll unpack it just now, has been able to expand borders across Africa and beyond, and even shown that as the African continent, we can lead in pro-pleasure conversations online. So that to me is a proud moment to be able to see Africa as a net contributor of creative communications that is able to be inclusive and expressive and create a safe space, if not in the real physical world or in some of the clinics and healthcare providers, right? But at least just in front of a screen where messaging and conversations are actually sparking a feeling of safety or sparking conversation between partners or even reflective and introspection individually. So let me unpack that a bit more. So I think just to wrap up, I guess, the context on Africa. So when we look at the African youth, right? So Africa is going to be the world's youngest continent, not just now, but certainly by 2100, 2050. So increasingly, as far as where the world's young people are, you see the continent of Africa as essentially the future. And that has both great parts, what we call the demographic dividend, but also if there's not stewardship of resources, great conversations around sexual health and so on, then you actually have what some people forecast as a bit of a demographic disaster or challenges. But one of the things we were trying to do with this is center young people in the conversation, and not them exclusively, but really just in a way that they who tend to be excluded from conversations were a part of the conversation from the start. And two, for a number of them, according to a survey we ran with IPPF at the beginning of our work, we found that they're obviously, and this is obvious now, but we were able to unpack this at the time, they're looking at sex really as a form of pleasure and well-being. So they are warming up to the full definition of sexual health, not just a means of procreation or even as far as language and service and care, not just necessarily being seen along the safe or unsafe or the risk factors alone, but them sort of speaking and advocating for this concept of pleasure and how elusive or open it is. Secondly, they tend generationally, Gen Z and Gen Y to some degree, those that are having access to the internet and information across Africa are finding that the concepts of sex and sexuality that they've been told, that they've observed, are different. And as they find what's their unique expression of that, they're turning to the internet anywhere it exists and they can safely access it, because that can be a problem sometimes. They're basically exploring these questions of shame and stigma, and in some cases finding resources to either feel better and more at ease individually, that they aren't what people say they are, or they aren't, if they're being ostracized or stigmatized, that there is a world out there that's different. And last but not least, really, Africa, as I've said, from a legal standpoint, from a political standpoint, the entire LGBTQIA+ debate is being weaponized politically. And in some cases, people face grievous harm just for expressing themselves, or just simply for existing in a public way, amongst their communities. So this is the background as far as the African continent of what we were essentially operating within when we worked with IPPF and the Pleasure Project to work on the Treasure Your Pleasure campaign. And part of what really these insights and others led us to was, well, one, having the courage and conviction to just even taking a stand that is pro-pleasure. As we've seen in the WHO definition, when you're looking at dysfunction or disease or infirmity, those are part of the definition, but not the full extent. And so for us, it was to say, look, there are healthcare providers and centers and a variety of places that, in the physical sense, can have these one-on-one conversations, but digitally, why don't we introduce ourselves in places where the smartphone will be the chance for us to have a one-on-one and direct engagement with somebody in a way that is pro-sexual pleasure, pro-safe sex, and really sex positive on top of all of that. So in terms of just showing a bit of, I guess, some of the assets, which I wouldn't play the videos necessarily, but I'll give you a sneak peek at some. Really for us, one of the things that was so powerful in this is learning and unlearning symbols and signs and metaphors that were exclusive, that were suggestive, that in some ways were stereotypical, and we had to roll back on them. And the Pleasure Project was really instructive to us on this. I think I have one of my colleagues, the actual teammate of mine who led this project. Her name is Melanie, and she's here too. And this was such a great conversation for us to basically discover how we would create safety, or how we would spark and have conversations from the talent we used in the studio, recording the sessions, to everybody else. So ultimately for us, it was not just letting people know about their own bodies and how, they can be a source of pleasure, unto themselves, to just even appreciating sex, which, while that sounds like maybe a couple paces back, some countries, some places here, that's still, there's just shame associated with sex, right? Outside of marriage, leave alone where you have sex, in any and all forms it takes, right? So these were some of the ways that we were sparking conversations, and knowing that they would go to dark social. So they would go to WhatsApp groups, they would go to intimate one-to-one conversations between partners, and so on and so forth. So for us, it was to create enough for people to just start and have those conversations. Secondly, we sought to make sure that we, even as far as inclusion, even went to persons living with disabilities, and not only sought their feedback in the initial research, but ultimately tried to help them feel seen and represented in the content and the creatives and the messaging that we had all throughout. Started conversations around safe sex and on condoms, because even on the African continent today, there's still some work to be done here. There's been tremendous strides made, and some countries are doing better than others, but really just making sure this is also centered, and safety is centered here too, and also making sure that not only do we have inclusivity across the LGBTQIA plus spectrum, but sparking safety in the actual content, so people know that this campaign is looking out for them and is inclusive unto them, and making sure that as people interact with IPPF, the organization, they can be passed on to their actual members in these respective countries, who can then provide care or interact with them as they consume and get met with the content from the campaign. So, I mean, this is just a quick snippet. As I said, I won't let the full thing play, but they make this available. Yeah, so that I guess that's like a quick snippet. But part of what we were going for here is what you see is in English, but we did have content in Portuguese, and that went to Portuguese-speaking African countries like Angola. We had content in French, and that went to Francophone or French-speaking countries in Africa. So we were able, out of Nairobi, with a Pan-African team at Nendo, to create content that felt local, that felt nuanced, that hit at some of the Pleasure Project's 7 principles. So just as far as being compliant and interacting with that material, and still finding ways to adjust to vernacular or just the local dialects and ways that people will express themselves. And so this is part of what we created. We did have a manifesto video that we made. I won't let this whole one play.
SEX, it's natural. So why not make the experience?
Yeah, just for time, I'm keeping my eye on the clock. But again, these are all available on, we have a landing page, and I'll point you to it towards the end. But what were some of the learnings and takeaways that we got? Well, one, there's the fact that you can target people through social media, but we faced a number of hurdles, right? So some of them had to do with the language we were using, seeing our ads disapproved, right? Or some of our content blocked, or some of the pages essentially getting strikes or warnings of some kind. And so that was not only because we're engaging with subject matter that has to do with sex and sexuality, but also really because really for Google, for Facebook, for Twitter, for Meta, these platforms, as much as they focus on the West, so Western countries, sometimes for Africa, they'll either sometimes flag things wrongly, classify them wrongly, and they don't always have the resources or the ways that we can appeal. And so we found particular hurdles in just reaching people that we were not expecting. And in some cases, we would try to appeal, but many of those appeals were unsuccessful. So what we try to do is change our tactics over time. One of the things that happened that was what I might call a positive mistake is in all the testing we had to do to circumvent ways that really we felt we were wrongly having our language classified or disapproved, was we ended up with our media buying, targeting briefly people in the USA, in India, and parts of Southeast Asia with the microsite we developed and with some of the content, and saw them really engage with it, meaning that to some degree, this English content was actually globally appealing, but that wasn't really our remit, so we quickly sort of turned that off. But it did validate in a small way, in a micro experiment, that the messaging was actually meaningful. And then last but not least, something that really took off for us was influencers, and how influencers really opened up. So there's a lady on TikTok by the name of Swiri Nyarkano, and she's based in Kenya. And we had Francophone influencers in French-speaking countries. We had some in Nigeria, and really across the board, from podcasters to really sex positive and people across the LGBTQIA plus spectrum to lend voice, and most of all, bring the currency of their communities, their virtual safe spaces, and basically advocate and create these pockets where the conversation could happen. Because as influencers, there's a way that they are able to have a direct line that even our campaign really had an extra boost to our strategy and our plan. And that was really fulfilling for us. So I think this was something that we weren't necessarily planning when we got started, but as we evolved the campaign and learned, watching those communities come and embrace the campaign was special. And I mean, just a quick maybe side trail, something we did that I know was really exciting for us is we created a number of stickers for places like WhatsApp and Telegram, so messaging and chat apps that could lend almost like a visual way to express oneself outside of chatting. And I mean, our aspiration was that they would sit almost like emojis in the regular conversation between partners, friends, and otherwise. So what did the campaign achieve? I'm almost at the end, I promise. I'm just going over time. So we did manage to break through a number of ways and had over 25 million impressions, reached over 9 million people across the 6 countries, and had engagement. Some of these can be interpreted as vanity metrics, but to us, they matter because of the hills we had to climb and challenges we had to overcome. And really just I'll give an example. So some people don't feel comfortable engaging with this material, but might take a screenshot and share it, because for me to engage publicly might be for me to bring out a message about myself and my sexuality that I'm not comfortable sharing, and certainly not making public to my social media acquaintances. And then eventually a number of people also following, but this is not something we were looking for, because again, people might be identified for following an organization like this or a campaign like this. So we had to work knowing that to some, we just needed to reach them, provide them the messaging, and know they might not engage, but that they would on dark social or elsewhere. So finally, we did create what we called a pleasure persona quiz. And it's really just one part of the campaign. There's 3 different archetypes, in a way of saying, that we came up with, and we're still working at this. We're still learning, and we don't by any means think that any of these 3 are binary, but it was just a way to start a process of introspection. So I encourage each one of you, whoever's interested, to try it. And I'll leave, I guess, the QR code up here for a couple seconds if you're curious, and we'd love your feedback on anything that we've made. And we know there's a long way for the African continent in particular to go. I mean, when I say that there are grievous harms, challenges, everything from the authorities to some, basically medical providers who, as we heard with some of the literature shared, are causing, some forms of harm to people who are coming and really seeking care. And certainly seeking even just a place to be heard and to interact, whether it's on the HIV side or their gender expression or sexuality. All of these are challenges that in the next decade we see the African continent having. What we think Treasure of Pleasure did was just start a way of validating, affirming, and exploring the full conversation virtually in places where if we brought a poster or a flyer physically, we'd never get past the airport or authorities, or we'd really be stopped before we start. We'd never get a billboard up. We took phones and were able to do that. So thank you again for the opportunity to share. And I appreciate the chance to be here. And over to you, Alison.
Thank you so much, Mark, for this fabulous presentation. I think that we can all agree that this campaign is incredibly meaningful to those that you have reached across Africa, but also to those of us who are in different countries and want to do similar work. So even though they are called vanity statistics, they are still incredibly meaningful and powerful. We would love for someone to come off camera if you have a question for Mark. I do just want to highlight part of your presentation, Mark, in discussing the importance of learning, but also unlearning symbols and signs that can create, these exclusive environments or conversations, or make anyone feel excluded from a conversation when talking about their sexual health. Also, the importance of helping others to appreciate sex, which I think is something that all of our speakers today have touched on, but also ensuring that whatever we're doing, that there is this importance of being inclusive and safe. So we appreciate your presentation so much, Mark. We appreciate all of our prisoners today and their presentations. And Natalie, would you like to ask a question?
Sure, good morning. Thank you for your presentation. I love just the optics and and the focus on pleasure. I was wondering if in your formative work, if anyone spoke to around the topic of consent, particularly around, gender and female body persons and consent, particularly around age as well. Did any of that come up in your formative work?
Oh, thank you so much for the question, Natalie. That was actually a really key pillar for us. And I feel I can't believe I didn't actually highlight it here. We were not even expecting the type of response and conversations that started just purely off of that. From people describing, I mean, in some cases, sharing, childhood traumas and challenges that they went through to, I mean, I don't even know how to broach the subject, but there are some countries more than others, but these almost patriarchal and historical African biases that even just in the language of consent, right, are such tough places to broach, because generationally, people really see themselves as not having to seek consent and seeing that as somewhat validated at very, very young levels, as early as even teenagehood, all the way back to where some particular African countries and communities continue to deal with female genital mutilation. And I mean, just in the last couple of weeks, I've seen on TikTok, because again, one of the challenges I think on Facebook or Twitter or Instagram, sometimes sensitive content like that will be flagged, and the creator wouldn't have the chance to voice their opinion, much less get the algorithmic push to start a conversation. But really seeing people come in and talk about what it was like and give their opinion. And some of them were, in the worst of cases, flown back from America, flown back from the UK, flown back from Western countries to Africa, taken to the rural areas and having these procedures go, essentially, without their consent, right? And so, yeah, I'd be remiss if I didn't highlight that was, for us, somewhat of a breakthrough in discovering just the extent to which people had not just things to say, but it had conversations that, even people who are seeing the content, seeing the comments and coming on and expressing that they were taking something from that, and it was having them rethink things in what we'd call the community management on Facebook and places like that. So yeah, I appreciate you raising that, because that did stand out to us quite a bit.
Thank you.
And so we have time for one last question, and I'm going to summarize some of the questions that have been in the Q&A session. And so for our preventers and thinking about everything that we've discussed today, I think that there's still a concern and almost fear among a lot of us in avoiding this sex negative speech. And so when thinking about, HIV, STIs, promoting condom use, how do we really make sure that we are discussing these in a sex positive light, and reminding ourselves or pushing ourselves to use less sex negative language?
I can go first. So one of the things, and I appreciate it, I've been listening to all of the different questions that have been asked and seeing all the questions in the chat as well. And one of the things that came up, especially during, like, for example, the Mpox outbreak this summer, right, was how do we discuss these topics while trying to decrease people acquiring these disease processes and not stigmatizing communities that have been historically stigmatized and discriminated against for years, and focusing on the facts, stating the facts as they are is really important. But at the same time, understanding, I really, really appreciate what Dr. Bond had to say of focusing on the person in front of you as a person, right? And being patient-centered and focusing on and remembering that whenever you're putting messaging out there, there's a person who's going to read this and how they would take that information. So whenever we're creating this infographic or information or all of that stuff in this messaging, I want you to put yourself in the shoes of being a patient, because I've been that patient. Many of us have been that patient, right? How would you read that information? How would you take that information? Would it empower you to want to go get tested? Would it empower you and make you feel comfortable going to that clinic and saying, I'm going to go to this place and I know they are not going to judge me and they're not going to shame me or try to tell me to do something. How can we make that messaging work for the majority of our individuals, and understanding that people are going to have sex? They want to have sex. Sex is good. Sex is fun, right? So how do we allow them to have that sex while creating a welcoming environment that allows them to come back every day, not judged, not stigmatized, not discriminated against, while also giving them the facts and information they need to create their own sexual health goals?
I totally agree. I think one of the most important things is to allow people to understand that they have choices and there are options available for them. And as a provider, as a public health professional, we're able to give them the information to help them make those choices to see what fits in their lives and stuff. And so, and that's where the empowerment comes in. It's like, okay, I can make the decision on what works for me, and I can learn more. There's so many different times when you even have conversations about condoms and the barriers of using condoms. Not a lot of people, even to this day, have full understanding of condoms and how they work. And also, like, like the functionality of condoms. They know what it's used for, but they don't know like the variations and that they have options even with that aspect. And then many people don't know about PEP and PrEP. And so there's so many different things that we don't look at, and giving people the opportunity to kind of create their own toolbox for themselves and figure out, okay, this is what works for me. And it's okay because all these things that I'm making decisions for are good for me and my life and my body, and that's acceptable. So that's another thing I really feel like as professionals, we shouldn't say, well, you have to do this. There's no have to. We encourage, we can inform them, but allow people to make these choices for themselves.
Oh, I love that. Yeah, I think mine is, I think just to look at the continent and say, while this is one of the challenges really, while a lot of people look to Africa and think, how can I help? And sometimes it becomes a mindset of pity or sadness, or just like this positioning that there's little I can learn, but there's a lot that I can give. That is helpful to some extent. I mean, one of the things I encourage people to do is, try to follow creators, particularly those, from the LGBTQIA plus community, engage and interact with their communities virtually. Some of that support and that, encouragement, and just really giving them essentially a global audience is part of, I think the journey. And then it's looking and knowing that there are privileges globally, not just to being in, I don't want to call it a developed country, but just being, really across the world that are there. And if there's ways that you personally, are led to help, to finding great organizations doing important work here on the continent that you can do, please go ahead. And then interact, I think, with a campaign. I think some of the work that the influencers, the podcasters, the YouTubers, just folks on Twitter and elsewhere did, for me, I mean, I learned so much from them because they were finally feeling like, hey, look, I might not work for some of the brands here because of the type of content I do, etc. But I'm going to make this because of what it means to me personally. And so, I mean, even for us, we would love to learn more about, and I certainly have learned a lot today that I feel we can incorporate into our messaging, and really grateful for the opportunity to share. So thank you.
Well, thank you again to all of our presenters. There are still so many incredible questions in the chat, the Q&A. They continue to come in. We are so appreciative of this engagement from our presenters and also our participants. All of our presenters have included their contact information. The slides and everything will be available online. And I personally encourage you to interact with them on Twitter because it is my favorite social media app. But we hand it over to you, Jim, to close us out. Thank you all again.
Thank you. This was really an incredible webinar. I do a lot of webinars, and I always think the webinar I'm doing is my favorite webinar of all time, but this really is, I think, at the top of my list, and it's going to stay there for a long time. I don't see how you could get knocked off from number one or number two. So a really huge thanks to all of you from all over the world, from Nairobi, from St. Louis, from New York, everyone who's been here, who joined us live, to the 500 plus who registered for this. big thank you to the American Sexual Health Association for all your support in helping pull this webinar together and helping bring in such an amazing audience. And I have to thank my new wonderful colleague, Alison, for her expert guidance and facilitation of this webinar. So thank you. As a reminder, all of these, the webinar has been recorded. The recording will be shared, the slides will be shared, a resource document will be shared. All of those are on the Choice Agenda website. You will all get an email when those things are available. We try to get those things up in a quick fashion. So in the next day or so, you should be getting that email. And I hope to see you, all of you, at many more of our Choice Agenda webinars. And if you're interested, join the Choice Agenda global discussion list, where these sorts of discussions happen all day, every day. So with that said, thanks again, Mark, Alison, Keosha, Joseph, every last one of you. Go have a wonderful day, take good care, and hope to see you all very soon. Thank you.